go up there or here?
No, you can stay right there,
All
actually.
right, perfect. So I'm going to give you all thank you very much. Thank you.
And you have to do it without the keyboard.
So I'm going to give you a brief presentation on chest tubes. This is what I'd like to refer to as more of like a hip pocket training. So something that we could do in a short period of time. Obviously, it's given 5 to 10 minutes. But it's really just to give you an overview of chest tubes. And in future classes, we can go into more of the chest tube device and more of the actual duties of the nurse in the care. And so with that, a little bit about myself. I have a little bit of experience managing chest tubes as a critical care ER trauma nurse at UCI in the emergency department. Also, I was a clinical nurse educator, and I've taught this numerous times. A variety of skills days for critical care, med surg, and ER nurses. And in terms of my credentials, I went to APU, obviously here. And I'm also an medical nurse practitioner in the Army. I went to the Army flight surgeon course. So before we get started, I just want to tell you a little about the pulmonary basics, who needs a chest tube, what the goals of a chest tube are, and then the management, and we'll wrap it up with what I like to think of the most important is really the day-to-day real-world experiences and how you're going to need to manage this as a new nurse on the floor. So in terms of the anatomy, you can see the lungs up there. The parietal pleural, that's going to be the inner wall of the chest. It's actually innervated by the intercostal nerves and the phrenic nerves. And so when you take a deep breath, it's going to rise and fall. In between that, you have the pleural fluid. It's a viscous fluid that helps the lungs slide back and forth against each other. And then you have the the visceral pleural. And that's going to be a serous membrane that lines the lungs. And that's going to be sliding back and forth. In its most basic function, the lungs function off a negative pressure system. As mammals, we have a negative pressure system. And so as we take a deep breath in, that's really where you're experiencing a negative pressure. Positive pressure is needed in the lungs, but unfortunately, we don't want the lung or respiratory and pulmonary system to become a positive pressure system. And that positive pressure system can occur when you have things like blunt or penetrating trauma that creates pressure inside the lungs that prevents the lungs from fully expanding. With that, that results in some decreased lung capacity and at the end, a decreased lung perfusion, which can result in shock and organ damage. So who needs a chest tube? This is why it's always important to know what you're going to be while you're treating your patients. And the most common cause is going to be a pneumothorax. And pneumothorax is where you get lung in that pleural space and the lung starts to collapse. The pneumothorax most commonly is the result of blunt or penetrating trauma. It could also be the cause in our populations around here of, say, a young, skinny male that could have some genetic predispositions and can develop it with basic shortness of breath. Those are going to be the main ones that we're going to see. It could also be a result of surgery. And so anybody that we have surgery or you're taking care of that's had surgery in the chest or thoracic cavity could develop this. A hemothorax is when you have blood occurring in the pleural space, and hemothorax in general is going to occur with truly that blunt or penetrating trauma. As I've mentioned before, this is probably second to tension pneumothorax, the most lethal cause and the most common reason that you need a chest tube. Tension pneumothorax, I apologize, a hemopneumothorax is going to be a mix of blood and air in the pleural space. So what I like people to think of it is when you think of air is going to rise. And so if someone's sitting up, the pneumothorax is going to occur up top, and then the hemothorax is going to drop. And we have many ways to see this, whether it's a chest x-ray, like you can see there on the right with the lung collapse, or you could also, if someone was laying supine, like we find most of our patients, we can find these things using a simple ultrasound, a bedside ultrasound, or we can use CAT scan, a variety of methods. Tension pneumothorax is really the reason that we put the chest tube in for the end stage. The tension pneumothorax really can shift the whole mediastinal compartment and result in compressing of the heart, which would result in decreased perfusion. And it You do things like even move the trachea to the right or to the left. And the unfortunate part of that is if this is not treated, this will result in death. So as nurses, it's our job to make sure that even if someone does have a chest tube in place, that they're still not developing that tension pneumothorax, and we can do that through things like a regular assessment. An effusion is another reason we need a chest tube. A chest tube, effusion typically does not involve extra air in the pleural space, but it's usually the result of things like congestive heart failure. And as you all know, that congestive heart failure is probably one of the most common reasons people are admitted and readmitted to our hospital system. And so with the pleural effusion, they develop all this extra fluid, back pressures, and we could go into that in another class. Another reason is going to be your pulmonary embolisms and pneumonia and infection. And I always like to put empyema on there because that's one of those things that we'll get into of one of the things you can do with a chest tube. But empyema is really a bacterial infection, and it's this real thick, nasty pus in there. And it's one of those things you may not get to see it very often, but when you do, it's a fascinating process. But you can see that it's extremely important that we have a chest tube in there. So the goals of the chest tube at the end state really are to restore and maintain that negative pressure back to the pleural space, and most importantly, prevent the development of that tension pneumothorax. At its most basic function, a chest tube is a straw and a cup of water. And so I have some cups for you all. I've got 4 cups here.
From our favorite place.
From your favorite place where I'm sure there's many students there. And so I notice you guys all have cups of water.
Hydration is very important.
So I need my way out, which could be Chick-fil-A.
Perfect. Yeah, it's going to take that. So I could pass a few of these out here.
Maybe nobody told me in and out this way.
One, and I'll keep one here. So this is the way I like to think of at its most basic function, a chest tube. And you'll see when we get into the real life applications to this in the nursing realm, what's going on. So if you think of, we created a positive pressure environment in a chest, and we can't have that air in the chest, so we have to get it out, and we don't want it to come back in. So if you put the tube into the chest, the side of the chest, and the air starts to come out, it's going to blow into the cup, like everyone can blow into their cup. And you'll see that the air can go out. It's going to rise out through the water, and there's no possible way for the air to come back in to the lungs, right? And so that's the goal. And there's a lot more details to it. It's not just that simple, but it's most basic function. That's how this was created. And at the end of the day, I'll show you that in the worst case scenario, if the chest tube comes out or anything like that, we can just put it in a cup of water. You're good to go. All right, so this is your typical chest tube drainage system. Like I mentioned in our next class, we'll talk about the parts of the chest tube drainage system. A lot of people refer to this as an atrium system. Atrium is actually the brand of the chest tube system. And so you don't want to get confused with that. Some of these chest tube systems, like the one on the right, you can see it actually is designed for hemothorax or hemopneumothorax because it has a method that we can actually collect blood. And some of them actually that we use in trauma, we can drain the blood, and if needed, we can auto-infuse it back into the patient. So from the nursing perspective, everything goes back to our nursing assessment with the chest tube management. So in terms of inspection, at the beginning of your shift and per your standard of care, whatever hospital or institution you're at, or per our textbook, we want to be inspecting the site. We always want to be inspecting the tubing and the drainage system. There could be leaks at any and all of those, and in the next class we can go over the practical hands-on aspects of inspecting those and making sure if we have an issue, how we can handle it. In terms of the patient, because we don't want to get focused on equipment and devices all the time, we want to look at always be assessing the lung sounds, the respiratory rate and rhythm, and their O2 saturation. And with that, we want to make sure that there's nothing really changing in the patient. And it's that the small changes in respiratory rate can be the initial stages of something catastrophic happening. And then in terms of the chest tube management system, we want to monitor the output, whether that's blood or if there's no blood, and the character and content of that. Depending on the institution you're at, they may have set standards of how much blood you're allowed to have come out of the chest tube before you need to notify the physician. And we can go into that wherever we have our clinicals. The most common complication that I've seen in terms of looking at incident reports myself and being involved in after action reports is people turning the stopcock or clamping the chest tubes. Just as you can imagine with this cup of water, if you clamp the straw, there's no possible way for that air or fluid to come out and escape. And so we're going to start to develop that positive pressure environment greater and greater in the chest. That's not something we want to deal with. So the key to this is really that continued nursing assessment. If you have questions, ask questions. They also like you to keep the drainage system below the patient, so that way you can have, you don't want to create any dependent loops, and also it helps me for drainage of the air. So to me, this is the most important slide in the whole process. It's because of the real world application. I think that's where we excel as nurses in the real world. So when you're transporting these patients, you may be worried about taking a suction machine with you. You may be worried about what's going to happen if you disconnect the chest tube suction. There's actually nothing you need to really worry about besides keeping the chest tube open and not clamping the stopcock. At the worst case scenario, if the chest tube came out in transport, or the chest tube did come out, you could put your hand over the chest tube site, the hole, or you could put, if it became disconnected from the tubing, you could put it in some simple saline or water. If the drainage system were to fall over, which is very common, or that doctor or nurse comes in and kicks it over because they like to hang at the end of the bed, that's not a problem either. There's ports that we can go over the next class, and we can reshift the water back and forth. We just want to make sure we keep track of how much blood or other products we had in there. In terms of the drainage system breaking, that's not a problem either. All these issues we can solve. So if that were to happen, we can simply do a short-term clamp and connect a new system to it, and we'll be good to go. The key is notifying your preceptors or whoever you're interacting with, and we can solve all of this. A very cool thing is you can draw blood in cultures from the chest tube systems, and we'll go over that process. Most people don't know that the chest tube tubing in general is a semi-permeable membrane, and you can actually draw, say we had that empyema or the bacteria, and we wanted to try to identify what type of bacteria is in there. We can do it that way. Leaks, something we're going to cover in another class, but we're basically going to work back through the system. Very easy to solve where the leak is coming from. This is a very rare situation, but subcutaneous emphysema. This is usually going to be the result of a very traumatic chest tube placement, and the patient's going to develop air up in the chest and a variety of aspects of the chest. This could be very dangerous. Sometimes you may see this though, and we just monitor these patients. But regardless, this is something that we always need to be reporting to the physician or whoever's managing the patient. Most commonly, you'll see your preceptors and other nurses or physicians, they like to melt chest tubes, and that's a process of pulling fluid out because, as you can imagine, it gets stuck in there. And that's something we definitely don't want to do. As crazy as it sounds, just by pulling on that, you can cause something called barotrauma. You can really increase that negative pressure in the chest. Negative pressure is great, but you're just creating this big draw on pressure. It's the ultimate suction on a straw, and that's something
Which they teach everybody to do.
absolutely, and it's not something we want to do. But the good thing is when we know the reason why we don't want to do it, it's much easier to explain to people. And then kind of the scariest situation that you all may come across as nurses is the dislodgement of a chest tube. And at the end of the day, all you really need to do is you could put your hand over it, you could put a glove over it, and just call for help, and we can take care of it from there. So here's the references that I used, and if there's any questions, we can answer them this time.
We're going to ask you lots of questions, but not
I figured.
necessarily about chest tubes.
Perfect, thank you.
Yes, we did.
Okay, yeah, that's funny. So go ahead and tell us briefly what you know about APU and the School of Nursing and what attracted you